Okay, our first speaker is Daniel, is that Towle? Towle, okay. And that's Dr. Daniel Towle.
Thank you. I am a Kansas City physician desiring to take part in the physician certification process, and my comments will center around the existing timeline provided by the state and some of the concerns and confusions that are already being experienced by patients. On the timeline you see there, where the June 4th is going to be the date that the physician certification form is available. That form is required for the patient to take to the state to get their patient ID card. The certification form is provided to the patient by the physician after an office visit. And then on July 4th is the first day patients can take their physician certification form to get their ID card. Earlier you showed a red ink warning, if you will, or alert to the general public. And it does state in there that the DHS wants to remind the public that any physician certification they receive for medical marijuana must be no more than 30 days old at the time an individual applies for their ID card. The problem with this is we're already seeing a lot of confusion in patients in the community of what event starts that 30-day clock. Is it the event of being seen in the office by the physician, or as some medical providers are saying, come on in now, I'll see you now, and then I'll just wait, and I'll date your certification form within the 30-day limit. I think that needs to be clarified, is what event starts the 30-day clock. Because I think it's important for it to be done, because uninformed patients are now rushing out to see their appointments, and they may find that appointment was not valid, and that they wasted their money. And the media is even having shows talking about and showing the first marijuana clinics are now open. I'm not sure they're really open based on what guidelines you need to come out with in terms of whether or not it's legal for them to see a patient now and then pencil whip the date in June if they want to. One of the final thing I would say is, from a perspective of the patient cost, if they get their card in July, the fact of the matter is that it's basically going to sit in their wallet or in their purse until December, January, whenever the product becomes truly available. So there seems to be a rush by a lot of patients to get their card, but now by the time they actually get buy a product, their card's going to be 6 months expired. Would you please give consideration for this first go-around if patients are getting their card between July and December of making that card valid for the entirety of 2020?
Thank you very much, Dr. I won't respond to every presentation, but I might on this one just briefly. Points well taken on the card, being able to, of course, it'll be an annual renewal fee on those cards of $25. So we'll take that back to the rule makers. But I think on the first part of his concern, very, very valid. And I think it just shows you that there's not been any rules out there other than what's in the amendment. And I think you may have a lot of doctors and clinics already jumping in prematurely. And so my suggestion would be to hold off on that too. I certainly would assume that if someone wants to start establishing a patient relationship with a doctor, with the patient and the doctor, that's fine, but that I'm pretty confident that if they sign that certification today, it'll be 30 days from the date they sign and date the certification. So I think those are some good points to bring up. Okay, the next presenter will be Justin Kendrick.
Hi, my name is Justin. I'm from Harrisonville, Missouri. I would like to suggest that a proficiency test or other kind of test be added to the previous experience required for cultivators. If you've lived in Missouri and abided by the law, you can't legally have any previous experience. And we have to hire people that are either out of state or have been out of state at some point to get the experience. And people in Missouri are pretty good at farming, and the marijuana is actually close to tomato plants in terms of how it's grown. And I just think a lot of Missouri farmers and citizens would be well equipped to do it on their own if they could just, do a test or something instead of having to rely on these people that are out of state and could potentially even gouge companies because they know they're necessary. That is all I have. Thank you for your time.
Thank you very much. And I'd like to remind folks to be sure and submit your request or your concern to us on our website, or if get it to us on the back of your form, or write it down for us, because that's how we'll get this information. We're going to take some notes, but we certainly won't be as detailed as you would with your concern. So please get that information to us on the website if you can. Next we have Darby Cook.
Hi, my name is Darby. I live here in Kansas City, Missouri. And just two quick recommendations. The first would be, as we continue to move forward, crafting these rules, I'd just like to encourage you guys to continue to respect the relationship that doctors have with their patients and not over-regulating what that relationship should look like. I think that's very unique to each patient and their needs. The second recommendation that I have is that when it comes to home growing, I know you guys have released a couple of possible rules so far. Again, as we move forward, I just recommend on that matter too, that we're careful not to over-regulate what people are doing on their private property and in their homes. From what I've seen in most other states, home growers tend to regulate themselves. Thank you.
Thank you. Vicki Ward.
Good evening. My name is Vicki Ward. I'm a Kansas City, Missouri resident as well. And I have 26 years experience in the field of substance use prevention. And I think most of my concerns that I'm going to address here on regulation really impacts our young people. And the first thing that I did want to say is that Florida passed Amendment 2 also that looked almost identical to ours. And I would strongly recommend that many of our policies reflect those. And those include things like warning labels and dose instructions on all packaging, product inserts to include dosage forms, strength, the physician's name, the patient's name, the dosing form, and the amount, the state that marijuana use, and also state that marijuana use is not approved by the FDA, and also list those side effect warnings, just as other medications do. Also to ban or restrict all marijuana advertising in Missouri. So restrictions to include the storefront marketing, discounts, images, no marijuana leaves, no fluorescent lightings. We do not see those on any of our other pharmacies. No advertisements that are visible to the public other than a single state approved logo that's been approved by the Department of Health for all dispensaries, and Florida has done that. Follow medical standard forms only. That would mean pills, capsules, and liquids, and no edibles. Child-safe packaging in compliance with the U.S. Poison Prevention Act. Packaging restrictions, no images that appeal to children. Limit potency of the THC in products to 15% or less. A minimum age of 21 for all purchases of marijuana and for employment in the medical marijuana industry, including training and background checks. Maintain some impairment laws that address driving under the influence of any mind-altering substance, and prohibit dispensary hours between 9 p.m. and 7 a.m. I also brought to leave with DHS some pictures of what the dispensaries look like and how they market in Colorado versus Florida. And you're going to see extreme differences. Those in Florida look like medications. The others look like a candy shop in many cases. So I did want to leave that with you. And thank you so much.
Thank you very much. Brian Hunt?
Yeah.
Hun, did I get it right?
Yeah.
All right.
Hi, my name is Brian and I'm from Las Vegas, Nevada. I'm currently in the industry. We own a couple dispensaries in Nevada, cultivation and production facility. I think a couple things that I think you guys are in the forefront of, maybe taking some of the things that we learned what's in the markets right now is, I know there's a minimum requirement of dispensaries and cultivation and manufactured lips, but I think you might want to look at capping those as well. I don't know if there's, I read the amendment, there's no cap per se. There's 2 states in the United States that doesn't have cap, Oregon and Oklahoma. And there's a lot of black market activities going on in those 2 states. So a lot of Oregon, there's so much abundant growth of cannabis that I think 90% of the things that they grow ships out of the state of Oregon. And if I was just in Oklahoma just the last 2 days, I'm looking at dispensaries that are basically buying flower or other materials from Colorado or Oregon and bringing to state line, because there's no enforcement as well. I think you guys did a great job of taking the pre-application, getting the funding so you can enforce. I went to several dispensaries in Oklahoma and some had nothing. Somebody had 70 different strains and somehow he magically got it and no one else could get it. So I'm assuming they're getting from, there's rumors that they get it from Colorado, other states across the country. There's no enforcement going on right now. Also, what you guys might consider is there's, in the state of Nevada where we operate, there's no, you could have a dispensary in a commercial zone versus a M1 zone or industrial zone, where some California cities will only allow dispensaries in industrial zones, which had 2 consequences, which was it was a very restricted area where they could have dispensaries in cultivation and nip operation, and that drove the real estate market really high in that area. So a lot of people had to pay rent that was 3x maybe the market rent, or they were trying to sell it for, let's say, $100 square foot warehouse. They're trying to get $400 square foot warehouse. So you locked down a lot of people that can get into real estate, that can access real estate. So I know there's schools about 1,000 feet away from schools and children, which is I think common across all state lines. But I think you might want to let, as long as it's in a commercial area, it meets those requirements. That's not to the hindrance for the business to be operated in a commercial zone area. So that's all I'd say. Thank you.
Thank you. Jessica Kelly.
Hi, I represent the local chapter of NORML, which is the National Organization for the Reform of Marijuana Laws. Our chapter was instrumental in getting this initiative put on the ballot and passed. And I have a couple suggestions that our chapter would like to share with you. First, we would like to thank you for holding these public forums to allow the public to give their input on the process. And we would like these forums to continue as the program is rolled out so that the department can continue to check in with the patients and advocates to ensure that the spirit of the amendment is being followed. Amendment 2 was written first and foremost to protect patients and caregivers. We suggest setting up advisory positions or an advisory panel to the medical marijuana department, which would be held by advocates, patients, and caregivers. These should be people who are not affiliated with the industry and instead can specifically advocate for the interests of patients and caregivers. We also recommend updating the draft rules regarding residency requirements, where it states that the patient has, quote, the intention of permanently or indefinitely residing in Missouri. This is prohibitive and places an undue burden on the patient. We request that the department allow for reciprocity for qualifying patients from other medical marijuana states to be able to access medicine in Missouri. The patient ID and physician recommendations should be renewed every 2 years instead of yearly to help keep costs down for the patients and for the program. There also needs to be an appeals process for those patients and caregivers who, for whatever reason, have their cards taken away. A process by which they can defend themselves or correct any errors is one that is patient-focused. The department should also not implement any rules and regulations that make it virtually impossible for patients and caregivers to participate in the home cultivation of medical cannabis. The use of, quote, security devices should be clearly defined by the department, and these should not be costly to the patient in a way that would make them unable to participate. The limit put on non-flowering plants needs to be increased. Plants get sick and plants die. Patients and caregivers need to have access to enough vegetative plants in order to produce enough medicine. The original amendment did not put a limit on non-flowering plants. We also request that an independent body score the dispensary, cultivation, testing, and extraction facility applications to prevent any bias or corruption in the licensing, scoring, and awarding process. For the sake of transparency, the public should be made aware of what the scoring criteria will be and who will be doing the scoring. The department should not keep a list of patients who are on various forms of state financial assistance. Instead, the dispensaries themselves should set up their own programs for verifying this and assisting patients with the cost of their medicine. The department should encourage the housing department and landlords to respect the rights of medical marijuana patients and not evict them for participating in the legal program. We suggest that the department award cultivation licenses first so that patients will promptly have access to their medicine. Getting a cultivation facility up and going and producing product takes time, and patients need safe and legal access to their medicine as soon as possible, because without it, we are suffering. We would also like dispensary product packaging to include a clear breakdown of all of the cannabinoids present, not just THC and CB. Again, we appreciate you taking the time to meet with the public regarding this important program, and we look forward to working with you as the program is implemented. Thank you for putting patients first.
Thank you. Like I said, if you can give us a copy of that, I can't do short ones, so I appreciate that. Okay, Laura Bruce.
Hi, my name is Laura. I'm a resident of Kansas City, Missouri, and have worked in the public and behavioral health field as a program development specialist for the past 10 years at Tri-County Mental Health Services. Today, I come on behalf of the 18 prevention coalitions with 800 active members that work to promote mental health and reduce substance use in youth within Clay Flat and Ray counties. On November 9th, 2017, I attended an event titled the Missouri Opioid Crisis Summit, hosted and coordinated in part by the same department charged with setting up the rules and regulations for medical marijuana, the Missouri Department of Health and Senior Services. At this event, I remember your director, Dr. Randall Williams, giving the opening remarks about the incredible problem that our communities and state are encountering in regards to dependence and overdose on opiates. He called it an epidemic. I remember sitting there thinking, if only we could go back 10 years and set rules and regulations that would protect our community from the harmful effects of opiates. What if the state health department had been out ahead of this problem, instead of behind it to clean up its mess? I thought of how much money and time we could save. I thought of how many lives we could save. And that brings us here today. A year and a half later, the Missouri Department of Health and Senior Services making the rounds across the state. Instead of opiates, the drug is marijuana. Instead of swooping in with limited resources after use rates are at epidemic levels, you're spending your very valuable time trying to determine the rules and regulations that could protect our public health from another dangerous and addictive substance. It is not the job of the Missouri Department of Health and Senior Services to protect the marijuana industry. It's your job to set rules and regulations that will protect and promote the healthy living of families and seniors. Public health is leading the discussion regarding tobacco prevention, and it's working. Our rates are at all-time lows. We've seen incredible success in passing Tobacco 21 ordinances in our state. Our comprehensive approach towards marijuana is working too. Our youth use rates in Missouri are well below the national average at 11.8%. Many people at these sessions will use slivers of science to tell you that marijuana is not harmful. It reminds me of the slivers of science that Big Pharma used to tell doctors that opiates were not addictive. We know better in public health, and therefore I encourage you to incorporate the following requirements. Require age 21 to purchase, sell, cultivate, or be employed in the marijuana industry. Impose strict limits on marketing. Use a tracking system to limit the volume of marijuana products sold or purchased. Require extensive training or qualifications of dispensary staff, just like we require with all other Schedule 2, 3, 4, or 5 drugs. Require the products be sold in packaging that mirrors prescription drug packaging, no flashy colors, names, or child-friendly images. Limit dispensing hours. Limit edibles. Require product inserts similar to those that are provided with all other drugs. Thank you for listening, thank you for taking this job seriously, and thank you for doing everything in your power to protect our communities from the impact of medical marijuana.
Thank you. Robert Hoagland. Okay.
Hi, I'm Robert Hoagland. I'm from St. Joseph, Missouri. Just basically two things. Since this Amendment 2 is kind of set up to help veterans with the 4% tax that's coming from it, would it be possible that veterans would be able to get somewhere, just like in being hired for a federal job, they have preference, especially if they're a Missouri resident? And my second thing was just the amount of time that we're having if we do get a cultivation license. If you can go till the 31st, it's what that was brought up before. You're not going to have enough time to grow product by January, especially if you're going, seed to sell. And that's all I got. Kind of took my stuff.
Thank you. Daniel Goodman.
Yeah, good evening. My name is Daniel Goodman. I am a lifelong resident of Missouri. I've lived in Rake County all my life, and I appreciate your all's time being here today. And I would like to discuss a few things as a prospective grower that, and I have communicated this already through the email system that you guys have set up. That website's great. The state, we're requesting with the state regulators that they consider two categories of growers. A small business type grower, maybe with a maximum square footage regulation, and a large corporate grower. I've spoke with several other states about their growers, their cultivators, and I know some states pretty much are only a corporate type grow, but we're requesting that the state categorize those two where they can regulate them separately, because the small type grower can never compete with some of the facilities that I've seen in my research, like 500,000 square feet up in Canada, growing facilities. We can't compete with that, but this is definitely going to be a life-changing event for like that one person was up here just said. We're here to look after the best interest of the patients and the caregivers, but it's also going to be a life-changing event for those who will grow and manufacture and dispense the product to the patients. So, thank you very much.
Thank you. Julia Mees.
My name is Julia Meese. I live in Liberty. I'm a mom, a licensed physical therapist, and the director of a local nonprofit for youth substance use prevention. I have concerns about the increased availability of cannabis to youth and decreased perception of harm of cannabis that will come when Amendment 2 is implemented. Cannabis consumption in adolescents is associated with increased risk of developing depression and suicidal behavior later in life, even in the absence of a premorbid condition. THC is harmful to the developing brain. I would like to see Amendment 2 implemented in a way that protects kids so that they can grow up to fulfill their potential and live their lives free from addiction and mental health issues. I have a variety of suggestions to make. Each dispensary should operate under a medical director who is a physician or pharmacist. Physicians should be in charge of not only diagnosing the patient, but the physician should also have the responsibility of actually recommending cannabis, including the type, THC content, dose, and duration of treatment, as is typically done with medicine. If cannabis is to be used as a medicine, then it makes sense for a physician or pharmacist to be available to counsel patients regarding indications, contraindications, and potential drug interactions of the cannabis. When doing chart reviews in the hospital, it is common for me to come across patients with 10 or more medications as well as 10 or more diagnoses. A dispensary owner with no minimum education or training would not be able to safely dose and recommend cannabis for a patient with complex medical history. They will not know how cannabis affects each medical condition, as well as potential interactions with each pharmaceutical. Under Amendment 2, children of any age can consume marijuana legally, simply with a doctor diagnosis and parent approval. Starting at age 18, parent approval is no longer necessary. There must be adequate safeguards put into place to require ongoing physician monitoring of all patients, but especially children and adolescents, to prevent harm to the developing brain. For the number of dispensaries, start as small as possible. The stated minimum of 24 in each of 8 congressional districts. Data shows that the density of local dispensaries is associated with greater number of hospitalizations with the Marijuana Abuse Dependence Code. An additional 1 dispensary per square mile in a zip code was associated with a 7% increase in the number of hospitalizations with the Marijuana Abuse or Dependence Code. Do not allow minors into dispensaries. Prohibit the dispensing of medical marijuana to pregnant women. Prohibit those under 21 from working in the medical marijuana industry in any capacity. Do not allow edibles to look like candy or cookies. There is no need for medical cannabis to take the form of gummy bears. Warning labels should be on all products and posted in all dispensaries, similar to tobacco warnings. Warnings should state that marijuana is dangerous to the developing fetus, should be kept away from children, is not approved by the FDA, and that one should not operate machinery or drive a vehicle while under the influence of marijuana. The definition of a patient-physician relationship must be clearly defined. The physician should have to complete an in-person examination and risk analysis for the patient before recommending marijuana and maintain an ongoing treatment plan. The physician should have treated the patient for at least 90 days before recommending the use of marijuana. Amendment 2 states that all edibles be sold in individual labeled child-resistant containers. It would be best for children if these packages are not appealing to youth. For instance, Florida packages medical marijuana in white packages with plain labeling that look like medicine and are not appealing to youth. Require that when drivers undergo alcohol testing for any reason, that testing for THC metabolite also occur. When creating the budget for medical marijuana, include provisions for youth prevention, law enforcement training, and regular compliance checks of dispensaries. There are probably many in the room that are concerned with profiting financially from medical cannabis. Others are hoping to benefit health-wise. My plea is that you also consider the ramifications of this implementation on long-term youth marijuana use rates, traffic fatalities, school suspension rates, mental health diagnoses, suicide rates, and treatment admission rates, all of which are expected to rise with the increased availability and normalization of marijuana that comes with medical marijuana legalization. Please implement this legislation slowly and cautiously with the safety of our children and society in mind. Thank you.
Thank you very much. I'd like to remind everybody to be sure and get their notes to us, or be sure and put them online. We definitely need that information. Thank you. Joni Harshman.
Good evening, my name is Joni Harshman. I'm an attorney in Kansas City. I want to address the purchase and possession limitations. I feel that the 4-ounce limitation per month should be increased. I think that should be a case-by-case basis. Perhaps a patient's doctor can have input on that. I think the requirement of the 2 certified physicians in order to have more than 4 ounces is going to cause another hurdle for the patients and increase their expense and time into the process. It may be difficult for them to timely get 2 different doctor certifications within 30 days. And so I think that the 4-ounce limitation as a base start should be increased so that there are more patients that have more reasonable access to the amounts that they may need, because obviously that's going to vary on a case-by-case basis. I think that also it appears in the draft of the qualifying patient and primary caregiver form, that there's not the other products addressed, like edibles or the oils and things like that. There's patients that probably prefer not to smoke the medical marijuana, and what are their limitations going to be? And it shouldn't be limited, and you should consider the fact that there may be people that are not going to smoke any of the green leafy marijuana, and they need to take their medicine in other forms. And I think that you should consider that there are multiple different forms, and everybody is different, and some forms are going to be more suitable for others, and some people are going to have different access depending on their mobility and ability to access the other forms of marijuana, such as the oils and the edibles, and what can be distributed to them, or if they are not mobile enough to get to a dispensary by transporting themselves there. And lastly, I just want to say that I feel that the that access to the medical marijuana should not be a difficult roadblock and hurdle for those that are in need of it. We don't have the same difficult roadblocks to get prescription medication or alcohol, and we all know what kind of detrimental and negative effects that those can have on people's health as well. And just want to say that I respect the department's approach, and including the public's input.
Thank you very much. George Boswell.
My name is George Biswell. I'm a can evangelist, all things cannabis. And I've been working since 1976 off and on to get this, so it really warmed my heart when you said that you were head of the marijuana task force section. That was really great. What I just want to say, I appreciate the transparency that this section is doing for this, but what I do not want to see you do is over-regulate this industry. You will go to a black market when you start over-regulating some of the suggestions today. So I would just hope that you would keep that in mind. Thank you.
Casey Stark.
Thank you. Good to see you, George. Hey, good evening. My name is Casey Stark. I was born in this town a long time ago. I learned to read, write, and ride a bike, joined the military, and left. For the last 10 years, I've been selling marijuana across the planet, legally in Colorado, medical, and recreation. For the last 5 years, I sold everything I owned and focused on education. We have successfully launched operations from Alaska to Florida. You have a gargantuan mission ahead of you, but it does not have to be Herculean. I'd like to just mention to everyone here, for state of record, I will quote from the February article in Florida. Since legalization of medical marijuana at the ballot in 2016, Florida voters have watched an ongoing saga of political and legal battles over the implementation of the vote. The state legislature approved the bill and has seen a river of lawsuits quickly following. The Supreme Court recently overturned limits. If anyone knows medical marijuana, Florida is the worst example. And I find it somewhat hypocrisy that the opiate, those who represent drugs and recommend opiates, would come here tonight and suggest that Florida, and that's from February 2019, if you want lawsuits, follow Florida. With that said, I'll go just straight through this real quickly. I want to help. If we go line by line, there's several things that are awesome. This amendment is fantastic. But you do have the power, according to this, such other matters as, to regulate, and you shall, it does specifically state to those who oppose this, protect the patient, not the pharmaceutical companies, not opiates. We'll go real quickly. Is that my timer? 3:21, fantastic. Let's go to page 1. If we look at the qualifying conditions, knowing that your mandate is to protect the patient and the industry, it says a bunch of conditions, and then it says a chronic medical condition that is normally treated, quote, any terminal illness, quote, or in the professional judgment of physician, any chronic debilitating wherein, or other medical condition, unquote. I think it would be wise if we took out everything except just those 3 words, in the professional judgment of the physician, because it's really just mute. We list the words cancer, we wish, and I've seen people, I have 30,000 patients. I understand the necessity, but it's redundant, it's confusing. Why not just say in the professional judgment of a physician? It says it already. So that means everything above there and then some. That's easy, we can fix that simply, strike it. It says here, a department shall certify at least 2 commercial testing. I grow marijuana, I grow hemp, we've done it all across America. If you have 2 centers, it'll never get tested. We have 60 in Colorado.
They need more.
Thank you. You just can't do it. You're creating a big mess. It takes us, when we first started, it took over 45 days to get tests back. Now I can get it in a week. No problem, but that took 10 years. Don't do that problem. It will never get to market. 2 labs, or we make it a monopoly, a casino, or is it to protect the industry? Rip the top off it. It says you shall and you can. You have the right, it's in there. If we go to the system of testing, it says here veracity, etc., etc. I'm not sure how you measure veracity. I'm not sure how you do this, but let's look at this real quickly. I have some information here that if you take a map, and I'll show you. If you take a map, this is the drug-free zone, 1,000 feet circle. This is a map of churches. This is a map of churches and schools. You may not know it, but there's 2,271 congregations in Missouri. If you do a circle that we have around churches, you will find that there's hardly any place that you can do this with a 30,000 square foot property and provide it and protect it and give it to the patient. That's just crazy. A matter of fact, the worst 2 words in here, and I've been baptized about 7 times. The first book I learned to read was the Bible. And churches. Do you know what Missouri defines a church as? Anybody? Anybody? I'll tell you.
2 or more people that follow the same way of thinking.
Not quite, but close. The IRS actually defines it as a place that has rites, sacraments, and rituals. That includes synagogues, seats, temples, congregation, youth groups, and believe it or not, Missouri is one of only 3 states that has a 2,000-foot drug-free zone. 2,000. That's a 1,000-foot circle. Make that 2,000 because you're breaking federal law. It says you won't prosecute me for state law, but if I'm in a drug-free zone, it's 2,000 feet. The feds come in, local sheriff doesn't like me, neighbor doesn't like me, call the feds, it's happened. Planes fly over, feds come in. Look at the map. I love your map. Add churches on there. Another question. It says buses. Missouri is the only state I've ever seen that declares a drug-free zone in a bus. So that means if I have a medical marijuana center and a bus drives by and this 2,000-foot rule, I mean, what does that mean? I'm just reading your law, but you can stop all this. You have the power to rip the cap off this. And one last word for everyone here that has paid that money. It says you shall protect this industry. You shall make it acceptable. Those are commands. It says a minimum, not a maximum. You are smaller than Colorado, or you're bigger than Colorado. I'll show you this. We have 640 medical marijuana centers. We have 664 cultivations, 240 MIPs, 470 dispensaries, 61 testing labs. You're asking for 260, 86, 192, having a scoring system, which that's going to be fun to watch. I can't wait to see the lawsuits out of that. Or you could say, well, there's no lawsuit. We're going to leave it up to the American. You all paid it. You have the right to lift the roof off it. It says you shall. And you can, you know that. So you can say, you know what? If you pass the FBI fingerprint check, I get it, that makes sense. Okay. But if your plan has like a little car or a big car, well, I'm going to give you just the right chance. I walked past a Jaguar over here in a Kia, parked right outside. They both have a car, they both have a license. I don't have the right to park there because my Jaguar is bigger. No, the little guy and the big guy needs a chance. If they pay that $10,000 and you don't give them the chance, you will face lawsuits for years. That's a pretty quick decision in Florida just happened, and that was 2014? You don't have to do any of that, man. That law is good. Take the word in churches, take the word in buses, take the word 2,000 feet, take the word minimum and say, yes, you're an American, you paid your $10,000, we're going to charge you $25,000, and let the laissez-faire American market decide. I'm way past my time, I think. I see this thing flashing. But I will leave this with you, and I will invite you to come to our cannabis incubator. It's right down the street, and I wish I could go to this more, but we'd love to have you. My name is Casey Stark.
Thank you. One thing I have to comment on this one, though, Mr. Stark, is Amendment 2 was voted on by the voters. It is now part of the Missouri Constitution. So we can elaborate, we can go further with the rules, but we can't subtract anything that's in our Constitution without another vote of the people. Just,
correct.
You know.
You don't have to take anything out to give everyone a license, do you?
Not on the license part, but on
Correct.
some of those things you mentioned, we have to leave in there. So.
Correct.
Yeah.
Thank you very much.
You're welcome. Okay, our next one is Monica Meeks.
My name is Monica Meeks. I work in the field of youth substance use prevention in Lee Summit and work with a youth population of more than 18,000 young people who live in our greater Lee Summit area. Lee Summit is the 6th largest community in Missouri. I am speaking tonight on behalf of Keeping Missouri Kids Safe, a statewide coalition of underage substance use prevention organizations and professionals. Research shows that 90% of Americans who are addicted to substances started using them before they were 18 years old. States with marijuana legalization for medical purposes have higher past-month marijuana use by youth. Research indicates youth living in states with more dispensaries are also more likely to have tried new and more potent forms of marijuana, such as edibles and marijuana concentrates in vaping devices. Existing research suggests that initiation of cannabis use in adolescence is associated with long-term neurocognitive effects. Just today, the Journal of Neuroscience reported a study presenting evidence suggesting structural brain and cognitive effects of just 1 or 2 instances of marijuana use in adolescents. The average age of first-time use of marijuana in Missouri is 14 years old. Age of first-time use is important as it can lead to dependence and addiction. In fact, 14% of youth in Missouri, middle and high schools, have used marijuana, with half of those using it in the past month. Marijuana is consistently shown locally to be the primary drug used among teens in substance use treatment. The average age of those in treatment locally is 13 years old, although children as young as 7 are in treatment as well. The cost to the community beyond its impact on youth and their family is far greater. Costs to local government for public health and safety are identified in Amendment 2. According to a new study out of Colorado, for every dollar gained in tax revenue, Coloradans spent approximately $4.50 to mitigate the effects of legalization. Costs related to the healthcare system and from high school dropouts are the largest cost contributors. Amendment 2 requires that caregivers who receive or cultivate medical marijuana on behalf of a patient be at least 21 years of age. We encourage DHSS to honor this intention throughout the implementation of Amendment 2 by requiring individuals to be at least 21 years old to purchase, sell, cultivate, or work in the marijuana industry. Implementing Marijuana 21 would help prevent illegal access and distribution, particularly among those under age 21 who are not certified to use marijuana for medical purposes. Marijuana is an addictive substance, and young brains are particularly susceptible to addiction. We encourage DHSS to ensure that implementation of Amendment 2 minimizes the risk of youth access and addiction. drawing upon lessons learned through the efforts to minimize youth alcohol and tobacco use by setting age 21 as the minimum age of purchase. By ensuring a consistent age of 21 in all of the regulations, this ensures not only that physicians but other valuable support systems are in place to help those young people under age 21 suffering from debilitating and chronic conditions described in the amendment. And should you not decide to codify age 21 for the purchase, sales, cultivation, and employment in the industry, please rule that it is not unduly burdensome and allow jurisdictions to make local decisions regarding marijuana 21. I would also like to advocate on a couple of other quick points. Research indicates youth who view marijuana advertising for medical purposes are more likely to use marijuana. We recommend that mechanisms for advertising should be limited, similar to limits on tobacco advertising. Regulations should address storefront marketing, such as discounts and images. Packaging restrictions should prohibit use of cartoons or other images that appeal to children. Social media marketing and pop-up ads, whether paid or earned, should not target those under age 21. DHSS is encouraged to provide sufficient funding to local coalitions for science-based public education campaigns across multiple media that discourage youth use, describe dependence and withdrawal systems, and provide a phone number to connect users to treatment, similar to the Missouri Quit Line. DHSS has the authority to limit the volume of product purchased. An electronic tracking system could be and should be implemented that would allow dispensaries to see if a potential customer has reached or exceeded his or her limit to decrease the likelihood of marijuana being diverted to youth under age 21. And finally, Amendment 2 explicitly allows for patients to utilize edible products derived from marijuana, but the allowance is not explicitly limitless. Regulations should restrict forms of edibles to decrease unintended use and accidental poisonings by allowing only medically standard forms and prohibiting candy names, flavorings, packaging, and products such as baked goods and candies appealing to children. Thank you so much for this opportunity to provide our feedback to protect the young people of Missouri.
Thank you very much. Sharon Ward Coleman.
Good evening. Thank you for this opportunity. My name is Sharon Ward Coleman. I am here today, and it's almost a miracle. Cannabis gave me my life back, literally gave me my life back. For the last 5.5 years, I was dependent on 18.5 pills to treat an illness called CRPS, short name for nerve damage, which pretty much caused me to be bedridden with skin burning from clothes touching my skin, electric shocks like pains going through my body, needle prickling pain all through my body as well. Literally, the pain was off the chart. With various prescription drugs and narcotics, my body was literally shutting down. Thank God for stumbling across CBD oils, which literally saved my life. And now that experience has turned my life into a pursuit of advocacy, justice, and equality, and economical development. Sorry, I'm very nervous. For the last 80 years or so, America has had a drug war since 1937 Tax Act, incarcerating Americans at a higher rate than any other nation in the world. Are we more criminal as the law? That criminal, legal, and justice is not the same. Today in Missouri, we have voted to turn back prohibition, authorization, acquisition, and sales and development and a product, and this purpose, but there is a problem. And that is over 70 million Americans in 1970 have a drug felony or charges on their record. Many of those people are in jail, and that those that are out of jail with the record cannot even get a job. And that is wrong. It is a hypocrisy of our democracy and an insult to the intelligence of our fellow citizens. As the community liaison of the Cannabis Startup Incubator, we work for equality and development, and I would suggest that it would be benevolent and prudent to immediately discuss impungement of those every minor drug possessions in Missouri now.
Thank you. There is some legislation, by the way, in the Capitol that is addressing some of those issues, just so that people will know. Jericho.
How we doing tonight, guys? First, I want to say thank you so much for holding this. This is important to people like me. I'm from Kansas City, Missouri. I've been living in Colorado for the past 3 years now, working in medical and recreational cannabis. And first, I want to say, I hope a lot of these people here who have had concerns about a lot of the regulation take a trip to Denver, Colorado, and really see how it works. I'll invite you to come see my facilities myself. So if anybody wants to talk, it's an open door. But a couple concerns that are big right now in Colorado, big things in the MBD and stuff like that. One being, when the draft rules come out for the testing facilities, are we going to have a draft of what panel tests are going to be used on the cannabis? And what are they going to be used? How are they going to be used? Are we doing microbials, pesticides? Are we testing for mycotoxins? All these things. If public safety and concern is a big thing, then we'll definitely make sure testing regulation is implemented quick and done correctly. Going down the line and changing things can be really harmful for a grow operation or facility. Allowing pesticides that you will no longer allow in the future can really harm someone's crop or the half-life of their genetics, stuff like that. Also want to know, so in the state of Colorado, we use metric through the MED and the Colorado departments. I'm wondering what system and software will be implemented from the states to govern the people, and when will that software be available to check out? Is that only accessible when you're granted a license? Because if so, we're already behind. That software needs to have panels and tons of talk about how the software is going to be set up and how it's worded and how it works. In Colorado, it's a very confusing thing going from your POS to your metric system. So it's something that needs to be laid out and understood for the people of Missouri before we get into this. It's very important. As well as regulation, I'm definitely here for the patients. I've been diagnosed with Crohn's disease for 3.5 years, and cannabis is something that I use daily, multiple times. And without it, it would be a very tough life. So to understand regulation, I'm also someone who's in the business and understand what it takes for a business to thrive. We all know 280E is a very tough thing and practically unbeatable when it comes to deducting anything within cannabis. What is going to be. We got to understand that these are local businesses. We got to be able to win too. If we get granted licenses, we can't be out-regulated out of being able to make $1. You have to be able to make money to grow as a business, especially a local business. So while, doing this and, this is for the patients, we have to understand that, some of these patients are going to be local business owners and, participating in that as well. So I think that's very important. But yeah, last but not least, I just really think a lot more of the community outreach programs and everything need to be set up. There is a lot of concern about the community and the youth and things like that. What about the kids who are 18 and have major medical illnesses that really need cannabis? It's proven to work for them and not be harmful as well. Just as much as it's proven all the other studies and things like that. As we talk about, a lot of people are going to be, smoking actual medical flowers. Well, kids are going to be using, ointments and ailments to get high, so to speak, or psychoactive. These kids are going to be using this for pain treatment and, similar things, inflammation, things like that. So it's just something that we have to understand that, maybe the regulations need to, be a little bit more clear on that, but, kids that are 18 up, with parent guidance, of course, they need access to this medicine as well. So, thank you.
Thank you. We are working on the RFPs, and they'll be going out real soon for all of the software. And of course, we have a state procedure to follow on that, so we're hurrying it as quickly as we can by following all of our state rules. But the POS system, the seed to sales system, the licensing system, it should all be tied together, and hopefully it'll be state of the art, and that's what we hope to do with that, and everybody will be happy with the system we end up with. Okay.
It is a very good system.
Pardon me?
Metric.
Okay, yeah. Yeah, I know that's one of them, yeah.
California
Yeah.
does now.
Okay. Stephen Watson.
Hello, my name is Steve Watson. I'm glad that you gave this forum. Basically, I just wanted to say that hopefully you would keep in mind the residents of Missouri. I think because we are ignorant of the laws and the procedures of the advantages of a lot of people in here that's from out of town, you should have some way of grandfathering us that live here the opportunity to be on the ground floor of this exploding new adventure. Most of us, we don't even know, what the rules are. You're setting regulations of what we don't know anything about, and we live here. The other thing I want you to consider, for me, I'm 70 years old. I'm handicapped, and my words are, what about us? The people that's in pain, the amputees. I'm cancer free. I just got through having surgery. They put me on opioids. I know that opioids are necessary for the excruciating pain that I've had, but I don't like them. Once you get off of it, what is your choices that you have? I'm a criminal if I smoke marijuana. Should I be a criminal? All I'm trying to do is alleviate my pain. Why should I be punished? For what? Look at your military. People are coming back PTSD. These people, they get disqualified for opioids if they smoke marijuana. What are they trying to smoke marijuana for? To alleviate pain. What about the people that's in pain that don't qualify for your rules? What about us? Or should we be them? I'm one of them. What about us? We're on the borderline of what we're going to do with our pain, because Tylenol doesn't do it. Ibuprofen doesn't do it. So what's our choices? To be a criminal? I've been here. I don't have a record. Why should I be a criminal now? Because I'm trying to alleviate my pain. So I'm asking to grandfather timing in for us to you're passing all these rules this year. So if we don't jump on the boat right now because of our ignorance, then we missed it. Everybody else that's coming in from other states, they're going to be the winners, of the licenses that's going to be here for the next 100 years. And then we all be saying, I wish I had known of the opportunity that presents itself in 2019. Thank you.
Thank you. Jason Lamont, or Lomont. Sorry if I got that wrong.
I'm Jason Lamont, and I'm from the Independence Blue Springs area. I have 3 things to talk about. 5 different states have written a provision dealing with gifting cannabis. This allows caregivers to gift a maximum of 1 ounce of cannabis to another medical patient if they cannot afford it. the country's capital, DC, you can gift up to 2 ounces. So how are you guys going to address that? Be one. And for all facilities, how will the distance be measured? As the bird flies, or how people actually get to a facility? So with 1,000 feet, And then also in regards to cultivation facilities, when will the facility be required to put a tracking device on the plant? Once the size of a clone is too small to put a band around and track. I know in Colorado they specify once the clone is over 6 inches, then it can be tracked. So those are my 3 things. Thank you.
Thank you. We are addressing the council for we'll be clarifying that. Rule makers are working on that. I think most of the states, don't they start the tracking when it becomes a flowering plant, when it moves from a clone to the next chamber?
To the veg stage.
Yeah, the veg stage, yeah. Okay, Jeff Krupkowski.
Good job.
Did I get it? All right.
Hello, my name is Jeff Krupkowski. I'm manager of River Market Hydroponics. I'm a member of Kansas City Cannabis Company. I have a bachelor's in genetics from Iowa State. Although I am primarily on the commercial side, my concerns are mainly about the patients today. And my number one concern is the limited to 6 vegetative plants for home cultivation, echoing Jessica from Normal's concerns. There are 2 ways that you're going to possess these plants, one of which is vegetative, meaning that you are getting it in the form of cuttings or tissue culture so that you know what you are producing, but this may be unavailable to many patients off the bat, and they may be forced to start from seed. And a vegetative plant, it is not producing drugs, obviously. It has the potential to produce drugs, and that potential is held within its genetics. And those genetics also relate to the entire spectrum of chemicals that a cannabis can produce, whether it's terpenes, cannabinoids, flavonoids, and even alcohols. So if a patient is limited to seed production, then there will be no guarantee of medicine at the end of even a cultivation cycle. So if we are going to be allowing these patients to have vegetative specimens, we need something in the law to state how they are going to obtain those. And anything that is issued by the government is wrong, just to say plainly. And if you are allowed 6 vegetative plants in your home, each of which would likely be what is called a mother plant, a plant in which that you take cuttings and tissue cultures from so that you can produce a reliable medicine. If you're only allowed 6 vegetative plants, that means you're allowed 6 medicines, technically. And for people who are taking 20 pills a day, those 6 specimens may not cover all of the chemicals that the individual needs from those plants. If those 6 plants do not cover the full spectrum of medicines they need to have in their body to function correctly, that means that they have to go out and then purchase their medication, which will disproportionately affect low-income citizens. On the commercial side, I would like some definitions for research and development so that we could breed our own new varieties, not rely on other states that have been doing this for decades. And if that could be specified in any sort of canopy square footage, or what has to happen to that same material after production, whether it all has to go to concentrates and batched for uniformity, or even if it all has to be incinerated it would be good to have definitions on research and development areas. And once these commercial licenses are issued, it is common in states that a whole series of lawsuits come forward challenging those licenses and appealing the ones that weren't awarded. This typically stifles the advancement of these organizations that have been granted licenses, and I would appreciate it if something were in there that showed that they can start operation from the time a license is issued and not have to deal with these lawsuits that are going to prevent medicine from going into qualifying patients' hands. If an appeal is granted and successful on the organization's part, it should really be an added license to the minimum that is already given out license-wise, not taken from another individual potentially and given it to those that was more newly awarded. And finally, I would like to address that disease has no age limit, and I challenge any substance abuse specialists in the room to talk to the parents of the children in need of these life-saving medicines. Thank you.
Thank you. Get a copy of your notes. Remind everyone to get us a copy of your notes. Sure appreciate it. Andrew Hicks.
Hi, my name is Andrew Hicks from St. Joseph. I grew up around some farms up there. It wouldn't necessarily grow the same thing that my grandpa and all them did, so I left. Went and gained the knowledge legally out of state. We need to lighten up on the genetics. We gotta let genetics come in, and we gotta find some better ground to the 6 plants of veg and the 6 other plants we can have in-house. That's not going to allow the patients to necessarily get all the terpenes or the CBA, CBAG, CBAC, THCA. We're going to limit what the actual patient can receive with only 6 plants, just like my man said, mother plants. If that's going to count as one of my plants, I mean, I'm just going to pull clones from it nonstop. So I can only have those 6 plus these other 6. We need to open that up to the 6 veg, maybe 12, 18 on the other side. Just because I have clones over here doesn't mean that it's necessarily going to come. Plants die, things go wrong. On the cultivation side, the dispensary, I'm glad you guys upped the licenses. Have a lot of potential growth here, I feel. It's unfortunate everybody's so worried about profit. That's not what this is about. This is not recreational cannabis at all. This is medical. I think a lot of people in here are forgetting that. Of course, there is going to be profits, and there is going to be money to be made, but hopefully the licenses go to the people that put the effort and the work in to get there. I mean, this is not a faint of heart industry. There's a lot of sharks. A lot of people are going to lose money. A lot of people are going to make money. I also feel that losing the right to purchase firearms is kind of just ludicrous, especially in the state of Missouri. Because I get a cannabis card, I can no longer purchase a firearm. I mean, most of us are hunters here. I don't know about you guys, but a lot of us in my area are hunters, so I can't purchase a new rifle if I want to because I am now armed as a citizen. I mean, there's a little leeway we got to let loose on that. The caregiving licenses, I feel like we need to up that to 5 patients maybe per caregiver per license. If we're only getting 1 license, 3 patients, I feel that the caregiver can take a little bit more on. As far as genetics coming in from out of state, I know that when all the seeds we purchase from in Missouri, which is fine after a year or 2, maybe even 18 months, but we got to have some window grace period. Even if we just give the caregiver the right to purchase from out of state, or give the cultivators 6 months from the time they get their license, we're asking for trouble by not allowing genetics in on that way. The 4 ounces a month, that's kind of, we need more clarification. So I can have 4 ounces of what? 3 ounces flour, 1 ounce of concentrate. Like, we need to up that maybe to 6 ounces and then put a little bit more clarification on that. No one needs more than an ounce of concentrated wax shatter on hand. That should last you the month, I would hope. I mean, and as far as the ladies addressing the packaging, I can tell you right now, no one in the industry is worried about putting a cartoon character on the package. If that's what you guys want to do, let's do it. That's fine by me. No one is worried about or trying to advertise towards kids. That's not what anybody wants. We're worried about patients. So if that makes anyone feel better, I'm fine and dandy doing that. I don't have to put a cartoon character on anything to sell it. It's going to sell itself. So, that's all I have to say for you guys. Thank you.
Thank you. Okay, is this Miguel Mendenhall? May have that totally wrong, but.
Pretty close.
Okay, sorry if I did.
Hi, I'm Miguel Mendenhall from St. Joseph. I just wanted to touch base on what my partner was talking about with the caregivers licenses. The way that's set up, we get 3 patients per caregiver. But I'm not sure about in this area, but in my area I have more senior citizens and more disabled people that are not going to be able to grow for themselves. So to figure that maybe in this room, 1 in 4 has the knowledge and expertise and the money to grow and have a secure facility. But in my area, that's not really, you're really putting patients at a disadvantage to not be able to get their medication until a dispensary opens. I did like what you guys did with the caregiving and patient regulations that you have released. If there's any way that we could go about adding the amount of people that can grow in one area, because it's a lot easier to protect and secure a larger facility. Like even if we just do it, like set it up like different cages that have magnetic locks, or even security lock that only the caregiver and patient have access to, that allows more people a chance to be able to get their medication before dispensaries go, because they're only going to be able to do flower at that point until dispensaries and the manufacturers are able to start doing the edibles and the waxes and the extracts. What was the other point we had? Then I think that was all I had added on to that. Thank you.
Thank you. I've got a question for any of you, just quickly. We've kind of been told that about 11% medical marijuana card holders nationally, I guess, cultivate, grow their own. Is that an accurate number? Would anybody have an idea of that? Like in all the states, I mean, just a general statement.
I think it'd be very tough to really pinpoint that number really.
Yeah. But I guess when I heard that, that's much less than I would have thought that it might have been. I didn't know.
Say depending on the caregiver too.
What's that?
Depending on the caregiver.
Yeah.
The caregiver is known to yield something magnificent. That's who they're going to go with.
Yeah.
If they can't necessarily afford to grow on their growing at home, you have the alarm system now. We have to worry about security, people breaking in, everything on that nature.
Right.
Sometimes it's easier to divert that security risk to a caregiver. Just like he was saying on the facility, there's no reason why we can't up a facility and this be this section for this caregiver, and they handle everything over there. Sharing the space is just going to make it more secure.
Almost like a co-op type thing.
Absolutely. I mean, it's like I said, this is not recreational or medical, and whatever gets the best for the patient, that's what we should be worried about.
Just make it so that no one doesn't have a medical card is allowed in that facility, and then no one that is not doing a lot of clinics is allowed to do that.
I've seen plenty where only he's on his caregiver, we're the only ones that are going to have access to that. There's no way nobody else can get in just because it's in one open bay area of sorts. Doesn't mean that everybody has access. They may be able to see it, but that doesn't mean they can get into it.
Okay, thank you. Thank you very much. Todd Scatini.
Thank you very much. Thanks for taking the time. My name is Todd Scatini. I'm a recently retired lieutenant colonel out of the U.S. Army. I just
I just retired out of the I'm the CEO of Cavalry Cannabis, but I'm also the Midwest Director for the Veterans Cannabis Project. We're a national organization kind of elevating the conversation at the federal level and requesting that the Department of Defense and that the federal government reduce the barriers to research on a national level so that we can really address the veterans healthcare crisis that I think we're in today. I'm really proud to be here. I think this is an important discussion. I'm really grateful that you took the time and that you go around and that you receive input from the citizens who voted for this. I was proud to utilize the democratic right that we have to collect signatures and put this on the ballot in the state of Missouri. I'm very proud of the activists that we worked with here in Kansas City. By the way, I should mention that the majority of the activists in Kansas City are all females, and just did a phenomenal job in this place. Well done. I think this is a really unique place to watch this conversation unfold. I don't know if you're watching this, but it's on a federal level, on a national level, on a global level. This is a true paradigm shift that is taking place with the re-legalization of cannabis and hemp. This paradigm shift is going to have multiple effects on a global level. We're talking about a social justice impact unlike anything we've ever seen, where we will have fewer citizens placed in cages for a plant that's never killed anyone. And we'll also have the best opportunity to address the healthcare crisis that we're in. There's an economic development impact that's going to happen where you'll have more tax-paying citizens providing capital into the government coffers. And you're giving people the opportunity to elevate themselves in a space where they've been put sometimes through prohibition. There's an agricultural impact that's going to take place and unfold right here in the heartland. And of course, the most important in my view is the medical advances that are going to be made through the increased research and access to this particular plant. So to address those things, we're developing a new industry on a global level. And I think that we as an industry should start to measure ourselves along those where we have impact on social justice, economic development, agriculture, and health and wellness. And the beauty is that we get to watch this new industry unfold here because the rules for it have yet to be written. And we get to make an organization, make an industry in the form of something that we can be very proud of. I think it's unique that we're doing it here in the heartland. Every time I talk to people and I say, I'm doing this in Kansas City, and we did this, and Missourians did this in Kansas City, they all say, really? They can't even believe that we're having it. But what really has happened here is that we have a blank slate. We have the best language of any other state that I have seen in the United States, and the best that I've seen on any federal levels, if you look at Canada or Uruguay. And so we get to kind of build this on our own. So I'm grateful for the opportunity to have the conversation with you all. And I'm grateful that all citizens get to speak on this because this is the democracy that veterans signed up to defend. So just a couple of notes on the thing. I agree with so many people already made these points, but I think the expedition of approval process for patients should be prioritized. And in terms of the industry, I think the prioritization of cultivation should be number one so that we can have access to medicine as quickly as possible. I believe that reciprocity of other medical cannabis programs is incredibly important. It will one help Missouri not be a flyover state anymore, and two, it's going to give people access to medicine and not have to force them to be federal criminals. And I'm just joking about the flyover state thing. I'm very proud of this place. And in terms of advertising, I totally agree that we should make advertising just as restrictive as alcohol. So, and I also think that we should move rapidly to expunge. So if you could just pass the message in Jefferson City that we would like to really, expunge records so that everyone can have a seat at the table and participate in this industry. Thanks very much.
Thank you very much. Appreciate it. How many veterans we have in the room? Let's all give our veterans a round of applause. Thank you very much for your service and our freedom. Dale Forrest.
How are y'all? I'm Dale Forrest. I've been born and raised in Kansas City my whole life. Basically, what I'm asking you guys to do is take recommendations from a lot of us in here. The way it's structured right now, you guys are saying that we don't have any experience growing marijuana. Nobody asked me about experience with tomatoes and bell peppers. Just asking y'all to lighten up on that, on any outside resources that want to come in here. Missouri has great farmland. We have great growers and great cultivators with great minds. That is us. Also, the lady who called marijuana a drug, the gateway drug, didn't research Adderall, Ritalin, any of that, because it's really not. First thing I was ever exposed to in my house was alcohol. It's not a gateway drug. We have to stop calling it a drug. It's a plant. You don't call the lavender plant a drug. You call it a lavender plant, sir. And I would just ask that truly give us people here in Kansas City true opportunity to grow some of the world's best cannabis.
Thank you. Mark Termina, Dr. Mark. I'll just call you Dr. Mark. How's that?
Hello, I'm Mark Termina. I'm a practicing gastroenterologist in Kansas City since 1985. I've been an active duty Army physician for 5 years prior to that. And I'm a member of the AMA, the Missouri State Medical Association, and the Kansas City Medical Society. All three organizations are against medical marijuana. I, however, am for it, and I have been called unethical from some of my colleagues because of that. I want you to know that I treat a lot of patients with chronic diseases such as Crohn's disease, ulcerative colitis, people who have chronic nausea, who have terminal illness. Since I've been practicing, I've seen a lot of advances in medications, but medications rarely improve all the symptoms, such as nausea, chronic debility, anorexia, that type of thing. So I think medical marijuana has a place. I also think that there are 18-year-olds that I take care of. I don't take care of anybody younger than 18, but there are 18 to 21-year-olds that would benefit from this. So there's a couple of things logistically I think that may be helpful. One is when you start the bona fide relationship, I think there was some input from the MSMA that you should have a 3-month waiting period before a patient would walk in and get a card, which would stop a doctor from opening up an office in a dispensary, for example, and getting a card. So that, I think, is reasonable. However, there ought to be some exceptions to that. One is for veterans. Right now, the VAs are restricting any of their physicians. They will not be able to write a qualification card. And a lot of veterans have qualifying conditions. Number two, a large number of health systems, such as St. Luke's, HCA, a lot of the health systems have prohibited their physicians from getting qualifying cards. So there's a lot of people who have qualifying conditions, unfortunately, that are not going to be able to have a bona fide relationship with a physician for 3 months, who are going to be out for 3 months without the access. So there ought to be some leeway in that, at least having a physician review that. The other thing is that the amendment specifically prohibits nurse practitioners and physician's assistants from giving qualifying cards. I think that also should be assistant physicians. I'm not sure you're aware of assistant physicians, but Missouri is one of the few states where a physician who's graduated from medical school is able to practice without an internship or residency, and they're under a collaborative agreement with the physician. That's an assistant physician that's limited to 3 years. And the reason that was approved was to improve access to rural Americans. For rural Missourians, it shouldn't be, assistant physicians should not be able to give a qualifying card. They should be under the restrictions of physician's assistants and nurse practitioners. One other thing was the issue about physicians having to register with the state to be a qualifying condition is of concern to me. I have a DEA license, I have a BNDB license. I don't want to be sort of targeted by the state for specific audits, on this. And I'm a little worried about that. If you're going to share, if you are requiring physicians to register with the DHSS to be a qualifying condition, whether that information is going to be shared with the BNDB, and I'm going to receive some harassment about being a qualifying physician. That's it.
Thank you. Very good points, Doctor. Would you confirm my cards? We may want to follow up with you on a couple of those medical issues. Thank you. Yeah, I voted on that assistant physician bill when I was in the House. It was a really good bill, and supported that measure to allow a little more access in rural Missouri. But I was looking here at the amendment, and I believe the intent was for it not to include those, just medical doctors and doctors of osteopath. But it does read state licensed physicians, so that probably should be clarified in the rules. So I'll take that back. Thank you very much for those good points. Okay. Well, this is a registered pharmacist. I believe it's Michael Durker. Deeker, sorry.
And I am a veteran, and I used my GI Bill to go to pharmacy school. That was 29 years ago. I've been a practicing pharmacist for 29 years. I'm a board-certified pharmacotherapist. I do want to thank you for the open forum. I'm glad to see Dr. Taramina here. I've had the pleasure to work with him before, and I think he'd be a great physician to help monitor this process. But I have grave concerns. I have grave concerns for our youth primarily, and grave concerns about the misunderstanding about what cannabis and the compounds in cannabis actually do to the brain and the human body, because we don't fully understand it. Years ago, it was all about the THC, then we found out about CBD, now we're talking about terpenes and other phytochemicals. We don't understand them. If we really understood mental health, we wouldn't have depression, we wouldn't have suicide, we wouldn't have a lot of the problems we have. But I can tell you this, it is a fact that people under 21, or under 25 actually, that frequently use marijuana during those formative years of the brain are at higher risk of suicide. They are at higher risk of depression. They are at higher risk of a lower socio-economic outcome in their life. That's documented. I have a study I'll give you. This just came out in JAMA Psychiatry February this year that documents that as factual information. So I'm gravely concerned about our youth. And the other thing I wanted to point out is the young lady that had replaced her medication with, I believe she said CBD. I'm a big fan of CBD, and we should always try that first because CBD doesn't have the psychoactive actions that damage young brains. Now, I have no problem with fully adults, 25, and we can maybe go 21, but a fully adult brain using these compounds for medical purposes, there is a lot of opportunity there. But we can't have it both ways. Some gentlemen said it's a plant, some gentlemen said it's a medicine. It's not both ways. It's either medicine or it's a plant. So it's a very complicated issue. As a pharmacist, I've been studying it, and frankly, Dr. Taramina is a rare breed in the medical profession. He understands it better than most, but most medical professionals don't understand cannabis because there's no good data. The stuff that's coming out of Colorado today didn't even exist 10 years ago. Yep, and there's a pharmaceutical company called GW Pharmaceuticals. GW Pharmaceuticals has brought things to the FDA.
Let's be respectful here now. Okay?
Thank you.
Please.
Thank you. GW Pharmaceuticals has been working on this worldwide. They have some products. They just got a seizure product, and somebody mentioned the kids that we're saving with marijuana. We're not saving kids with marijuana mostly. It's seizures and it's CBD. The product that was just approved by the FDA, by GW Pharmaceuticals, is from cannabis. It's called CBD. So there's a lot of confusion, and I just wanted to add some clarity and a little bit of expertise. I'm not an expert. I know nothing about the grow. I don't know everything there is to know about how marijuana works on people because nobody really does. A lot of people have good experiences with it. I know people that medicate themselves with alcohol. I know people that medicate themselves with other addictions. Cannabis is addicting. There is a psychiatric diagnosis called cannabis use disorder. It is a real phenomenon. So again, I wanted to point out those facts. I hope that we leave a place for CBD. CBD, to me, in the cannabis industry is where people should always start if they're going to try it certainly for pain and probably for sleep and anxiety, some other things like that, and even some of the GI issues it helps with. So I wanted to point that out, and so please leave a place for CBD. And I wanted to mention, to me, as a pharmacist, here's what safe medical marijuana would look like. It would have protection against pregnancy. There's a study shown in Colorado that as many as 60% of dispensaries recommend cannabis for pregnant women. The data is very strong that that's detrimental to an unborn baby. I can show you data. I'm a board certified pharmacotherapist. So that I'm concerned about that. Minimum age, I think, should be 25. Again, I know we're hamstrung by the law that was passed and the amendment that was passed. But smoking is another issue that I would like to have addressed on the medical card. I think there should be an option for non-smokable. Because really, we call it medical marijuana. Only thing that people are going to get is a card signed by a doctor. And most of the cards are going to be signed by probably a handful of doctors. Maybe 20% at most of the doctors are going to write for this. And most of the cards are going to come from a few doctors. And they're done. Once the patient gets the card, they're at a bud tender's hands. And I hope that we can build some training and requirements for bud tenders. So I'm running out of time here. I guess I'll go back to the medical card application. So my primary request is on the medical card application, have a pregnancy restriction box so the authorizer of the card could restrict that. Have a monitoring program for revocation. So a physician, I believe, should be able to revoke the card very easily if their patient doesn't follow up with them. I believe the medical application card should have an option for the physician to require follow-up on a regular basis, whether it be monthly, quarterly, or whatever. Non-smoking only on the application. So a physician, when they offer the card or sign the application, they can say no smoking. And again, I've studied this for a while. The only reason, there's no medical reason that I can determine to smoke marijuana. The reason you smoke marijuana, it gets in your blood fast and you get high fast. That's why you smoke marijuana.
Heals you faster.
Yeah, heals you faster, great. THC limitation content, I think that the physician on the card should be able to limit that. And dispensing employee training, I mentioned that. And allow municipalities to opt out. And I did want to mention that, especially with the schools, 1,000 feet is nothing. A half a mile is 2,500 feet. I would like to see it allow. I know it says no closer than 1,000. I would like a municipality to allow the 2,500 foot limit from schools. And you don't need a 30,000 foot grow house in the city. We got plenty of room in this state to put your grow house. So your dispensary can be small, and it should be at least 2,500 feet from the school. I just thank you for your time.
Thank you, sir. Thank you.
Here's the study.
Jack Mitchell will be up next. Okay, thank you.
It's already there. Spitting stuff out your mouth, you don't even know what you're talking about.
Thank you for the opportunity to speak here today. My name is Jack Mitchell. I'm with Missouri Hemp Improvement Company. We represent various people who would like to participate in the industry at different levels, and I will take these comments and put them into a document and put it online. I don't have that document prepared, just didn't get to it today. So some of the issues we've run across is, first of all, I just love the comment of having a home grow where you can co-op those. I think that's an incredible idea and opportunity, and I really hope that happens, because people doing that in their basements is not ideal. And I know law enforcement would love that one. Going over to some issues that I see on the seed to sale. There are only 4 or 5 companies in the country that have done this. Metric and BioTrack have 80% of the market. A lot of issues with that. Huge metric support. I've worked with huge technology. I spent the last year visiting probably 100 locations in about 10 states, read the laws of about 8 states, and pretty much worked on every single aspect of this. Huge difference in Metric is they have a real open system. They don't provide all the other softwares to operate the business. So they're taking data from all of those softwares and playing in a fair game with the API work. Whereas BioTrack, MJ3, they write all those other softwares, so if they're the seed to sell, they don't always like to play with all the other software companies, so it's a huge concern. And I'll outline that. Metric doesn't do that. They don't provide any of the operational softwares inside your operation, points of sale, any of those other things. It's a little unclear about the clones being sold from one grow facility. If you want to have a clone nursery, it almost appears like they have to be sold out of the dispensary. I think the law's pretty clear. You can sell, and dispensaries can sell clones to the home grow and the various, even other grows. But I think that's real important that these cultivation operations be able to sell the clones. In terms of the licensing, I think what everybody's worried about is just a fair playing field. I think most people can accept whatever criteria are out there. It's just we ask for as much detail as possible. And when you read through the criteria, obviously cannabis experience can mean 100 things. Character can mean 100 things. We know you can't tie that down exactly. We just like to know kind of what the Department of Health is thinking. So the more detail where all the applicants understand what the department is thinking and how they're going to look at it will be a huge service. And in terms of the lawsuits, Missouri's done phenomenal. You haven't had a serious lawsuit yet. You look at most other states, there's been multiple lawsuits at this stage of the game in terms of election, getting the administration up and going. So I think Missouri's got a great law, and I think they have a great effort so far by the Department of Health. Doctors, my hat's off to this doctor in the back. I mean, we've probably talked to 30 or 40 doctors about this. Most of the big systems, which as you know, the big systems are acquiring all the groups. I mean, there are like 2 major independent groups in Kansas City. The amount of doctors that can independently make their decision to do these certifications is extremely small. And we know a huge number of them in the groups that would love to be able to react to their patients because they're getting hit every day by not a few patients, dozens of patients. And their groups don't let them write the prescription or the certifications. So it's a huge issue. So we hope this small group of doctors that ultimately are going to be willing to take the risk and be brave in face of all the criticism and the other things, that we don't do things from the health department standpoint to discourage those. We sort of try to help and support that small group of doctors who are going to get out on a limb and really support the industry. So I just, again, we're working with several of the corporate groups, and we're not getting any of them over the line. So hopefully that changes in the future, but it's not going to be an easy one. Another major concern is we would like for the department to consider, after it does award applications, that it doesn't require 100% build out of this huge, or even if it's not huge, but the grows are going to be pretty significant operations, that they let these things phase as the market develops, because when you start out and you got 1% patient count in the first year or so, and 3 years later you got 3% patient count of the population of Missouri, you have an entirely different operation. And again, we think it's really important that people show the capacity and ability to build what they say they're going to build, but we think there should be some kind of a process to start out, get in the market, get some product on the shelves of the dispensary so the patients have something. I mean, a normal greenhouse operation could be a year or more just to get built, ordered, operating, seeds, clones, and we just don't want it to take that long. We want there to be some phasing of this. I just like to point out because I haven't heard it, there's been a lot of great comments, but I'd like to point out that this is a huge, enormous, estimates are US $70 billion industry right now, illegal. So you're not creating any industry. It's here. what you're doing is you're allowing the people who want to be law-abiding, the people who are patients, the ability to get a safe product. And I'm thrilled to death that it's the Department of Health and not, some alcohol or some other society or group that's regulating this. And we really hope that that continues into the future. So I just like to keep the focus on the fact that you're taking all the people in the state of Missouri said, let's take this huge industry that's here right now, and let's get these people safe, tested, regulated, and a good environment so they're not, the ones that are breaking the law aren't any longer breaking the law. So I talked really fast, and I think I sort of gave the comments on the most of the items here that I wanted to hit, and I will get a written document that just kind of reminds the group of those points and
appreciate that.
Thank you.
Thank you. Josh Wilson.
We did on time. Good.
Got a phone book I could stand on or something. Josh Wilson from St. Joseph, Missouri. So I had some questions and clarifications I'd like to offer and maybe stir some internal questions as well. So if we're looking at an average of 185,000 potential medical marijuana patients over the next 3 years, similar to the 197 in Arizona, you're going to average out, based on the number of dispensaries, about 500 patients a month. And each patient goes into a dispensary, spends maybe $500 or $50 to $100 a visit. That doesn't equate to a lot of profitability. You enter in and allow some grandfathering of other medical marijuana patients from out of state. Now we can have more of a business operation in place that can sustain itself. In adding in a certified physician and or pharmacist on staff, just based on what the internal numbers are alone, the overhead would just cover the cost of the pharmacist's license or annual salary. Then you add in product plus any kind of security. You see that the costs outweigh the ability to make a profit. So I'm not saying we shouldn't have some type of a regulation on training at dispensaries. We should make it feasible enough to allow maybe a tiering system from owners and operators to daily staff like managers down to hourly or whatever the scenario works out at. Other states that have done this successfully with possibly a continuing education program put in place, something like in a nursing program or therapy department. Along with that, I'd like to point out that genetics are a big role. Where are we going to grow? We have it here, but it's not legal, so what are you going to do, get some black market stuff and start growing it? If we look towards out of state, we have some viable options available. However, if we work with, let's say, the Department of Agriculture to find out the best matches to our locality and soil samples, we can pair up river bottoms, bluff, low soil, whatever it may be, to find the right type of grow to help those initial cultivators come out successfully if they're not going to an interim grow system. As far as transportation, excuse me, I'm kind of blind, getting old, just like a horrible menu at a restaurant. So I was curious, is it possible to reconsider the type of growing scenario that's in place? So if you're going to be a grower and you pay $10,000 for the pre-application with a $25,000 annual fee, you have 30,000 square foot of space or 2,800 plants externally. Okay, what if you'd like to be something like a mom and pop location where you can have maybe 100 plants, and in your facility, that's a dispensary, maybe you want to produce some edibles, bake some goods, have an all-in-one inclusive. I work in a rural setting where the community is largely post-retirement age. They can attribute back some kind of familiarity to the idea of it's grown here. They test it, they make it right there. I can sit down with my neighbors, have some coffee, maybe some of the baked goods, whatever it is, and if I know it's grown by this guy, and I see this growing operation, I can also use that for educational purposes. Specifically, I'm in Maryville. The college up there has a great agricultural department. So if we could team up with organizations like that to have in-house direction, some type of regulation, you get an all-in-one inclusive location that's more appealing to customer bases and different economic groups. Do you want, now there's nothing wrong with pharmacies, I love them, they're great, they serve a purpose, but when you're coming into something new in an economy that has largely viewed this as criminal, and we make it terminology-wise acceptable, like hemp-derived, medical-based, whatever it may be, and you can look at it. Hey, that's Joe. I grew up with Joe. He grows that, and the agri department out here is run by Mike. Mike runs all that certification. We know we're going to get some good stuff, and if we go over here to Trixie's place, where she grows it and sells it, yeah, I'm gonna come back as a repeat customer, and that word of mouth alone will take care of any marketing that's going to be necessary to avoid any appeal to quote children or people of innocence that might have some negative stimuli with it. Along with that, I want to point out that edibles in general, one of the things that they're needed for is palatability. When you have people with long-term illnesses, digestive issues, the inability, like a weight loss problem, being able to consume enough calories or nutrients is really of primary concern. Hand them a pill or something that's non-food based, and here, have another one of these. This is going to help you. They're not going to be able to put it down. So when it's paired up with simple carbohydrates, lipids, it's much more palatable. You make it something familiar, like a cookie, brownie, or a gummy type of, doesn't matter the shape, it doesn't have to be a bear. It could be a dodecahedron for whatever matters, but that color, that familiarity makes it more palatable and easy for them, because just to get it down, it's sometimes an act of God. So those concentrations seem to be a little bit higher on average, just for that reason. If you know Joe Smith can only palate one of these tablets a day, it better not be at a low dose, because if they take it at 9 o'clock in the morning, by 4 o'clock in the afternoon, they've regained that nausea, that inability to function, and inability to consume calories that they need to function and think straight. So there's some different variables. You don't have to look at just, does it look like a Snickers bar or gummy bears or whatever it may be, but you do have to think about what it's there for and who that client base is, and why it's actually developed. I was going to ask the security aspect of it. So store owners are going to be accepting cash. I can't run it through a bank. So now I'm at high risk of criminal activity. If I'm also a patient and have a card, I can't have a gun. What am I going to do to help protect myself? And I don't mean, do I need to have a bazooka or a laser cannon with me, but perhaps if we look for a different type of, or a different form of transactions that limit the amount of actual tangible cash, the ability to control security and safety of the business owners is more intact, and we can offer a variable that's least appealing to the people who are trying to provoke some type of criminal activity. As well, with that type of alternative transaction, we can now make it taxable to the point that business owners can actually report things, show that what they're doing is valid. If we don't have anybody that can make any money growing it, don't have any money that can make anybody selling it or testing it, how are the customers that need it, the patients, going to get a product that's worthwhile? It'd be great if we could just volunteer our time and donate what we do to offer these patients what they need. But in effect, there needs to be a reason for us to be able to do this and maybe support our own families in the process. That's all I have. Thank you.
Thank you. Okay, Brandon Boardman. Looks like we've got about 5 or 6 more. So.
Hello, my name is Brandon Borkman. I'm the owner of Show Me Hydroponics, a brick and mortar store in Grand Valley, Missouri. We provide equipment and training for patients, caretakers, and commercial cultivators. I'm also an applicant for cultivation and retail sales, and most importantly, a leukemia survivor. I spent the last 7 years cultivating commercially in Nevada and California, as well as partnering in 2 Las Vegas delivery services before the brick and mortar stores were allowed. I witnessed firsthand the pains of legalization. I have a few concerns with limiting the number of cultivation licenses. One of them is not all the applicants are going to succeed on their first harvest. That could be due to failing on tests, crop failure, or just failure to fund the program all in all. We have outdoor farmers that are going to be prone to, it's a seasonal thing. So there's only going to be a certain amount of supply during certain parts of the year. The same thing could be said for the greenhouse growers or mixed lighting guys. They could potentially be shut down for, say, December to, or from December to February, just because of the temperatures outside, the potential loss due to snow. We've seen a lot of that on the West Coast this year. A lot of greenhouses fail, crops fail just because of the snow. And these structures are also rated for the snow. I believe more small farms can ensure the success of the program and reduce shortages. It even has the potential to make prices more competitive for the patients. I also urge DHSS to fast-track patient cultivation and bordering commercial applicants. Because of reciprocity, the state has the opportunity to create additional revenue. Oklahoma has no testing and patients may seek tested product. Arkansas patients are currently having access issues, and Illinois patients are also having access issues. I'd like to see license holders get a window of opportunity to acquire genetics, such as heirloom genetics from medical states they were forced to flee to. We don't want to see the same seed to sale problem Colorado has had. It also limits the genetic pool and plant profiles to the patients. Dispensaries should not be required to have a doctor or registered nurse on their application, nor should they be allowed additional points. For years, most doctors and nurses only spoke on the negative effects, and it only appears to be a money grab. I think they should stick to writing recommendations for the patients. Lastly, I recommend the state to adopt the metric system over other tracking systems. This is because most growers and consultants that have returned to the state are experienced in metric over others. This will reduce training time and expenses across the board. These are just a few of my recommendations. If the department has any other questions, I'd be glad to help. Thank you.
Thank you.
Thank you very much.
Can I submit this in an email to you
Reverend
guys?
Chapin Walton.
To that
medical info.
Hello, I'm Reverend Chapin Walton, and I kind of bring an interesting concept on it. One of the new things that not new, but it's been kind of in the news and stuff lately is our cannabis churches. And I am Judeo-Christian, so we're not some far off thing that's trying to put in some stuff. We believe it was in the holy anointing oil. And we really are seeking to help get some of the information about cannabis out there, help people understand that it's new into the science of it, that the THC and CBD is just the start of it. We've got so many different cannabinoids and terpenes that we need to preserve and make sure are aware and that we use those properly as they come up and we find the uses. Because we've gone to some of these cannabis shop or the CBD shops and seen some of the research, but they'll give you a whole chart of the breakdown of various cannabinoids. If we're aiming towards CBD and THC, it's really going to restrict those and make it so we won't have as much effects as that. With that kind of said, one of the things I actually ran into with Health and Human Services, and like my daughter has epilepsy, and I knew cannabis would be something for her, so I kind of tried to get the ideas. Of course, it doesn't work here until this stuff came up. I was able to get the Epidiolex authorized for her and I even called up Department of Health and Human Services and said, hey, what do we do since 2 places are allowed with CBD? There was no comment on that. Like, well, you have a prescription. Like, yeah, but with 2 allowed, this is illegal. So that makes a concern to me that I could get in trouble with that. The only answer I could get from Health and Human Services, well, speak to your local law enforcement. I say, well, I've spoke to law enforcement in the CBD shops, and they say, well, the local sheriffs and stuff don't mind because people aren't getting high on this, and they're probably not going to pursue it. But with a young child, that's definitely a concern. If somebody had an issue, say, hey, you're not authorized to have that, because that's strictly what's going on with that. One of the other concerns that always concerns me is there's always this, hey, there's not much information about cannabis and what's happened in the past with it, what it does, all this, which I can't buy that. You can go out to like antiquecannabis.com and you can see antique bottles from Lilly and Merrick. And I know these big companies, they tested that definitely until it was restricted in 1937. They did their due diligence, made sure it worked, and it was number one medicine until it was taken out of the formulary in 1937. And one of the other things that concern me is like the $4 an ounce. One of our first ladies with one of my associated churches, Green Faith Ministries, is actually prescribed 2 ounces daily with it, so to fight her MS. So she doesn't get that much, but to me that would easily run up to the 4 ounce. And I've seen some people really in bad pain. If they really need it, that would be a terrible restriction. I'll leave it at that. The other thing that we run into too is trying to do church actions. We're not supposed to do church actions if we're involved in this stuff within 1,200 feet of us. I'm interested in helping our community not only get access to safe medicine, but also whenever there's issues, because I seriously believe that there is addiction problems. There are addiction problems with everything. There's sex, gambling, anything can be an addiction. And those people really need to have a spot where they can get assistance. So I'm not really sure if there's any options that we can kind of help with those kind of things, but I'm always wanting to pursue it and try to figure out how we can really help our community. That also kind of brings up to, I appreciated that somebody put in that we should grandfather people in Missouri. I think that's a good thing, because we're going to have, what would be a good thing, because we're going to have so many big people coming over here just pulling up things. Little people like me that run small churches and stuff, we don't even have an option to get that kind of funding for the most part. So we really can't offer a lot of those kind of services. And some of those things come up too, because I'm associated also, one of my head churches is Temple 420, which actually worked out of LA, but we've been continuously badgered, closed down when we were actually church, and then they opened up a second, which was Green Cross Ministries, and that ended up being taken down, told that our parishioner wasn't a real caregiver, he doesn't care for people, and it was essentially stonewalled and dismissed. So we've had trouble with that kind of things. I would like to see different things in Missouri to allow us who are faithful in religions and believe in cannabis also be able to access that.
Thank you very much.
Thank
you. Some of the problems that having a lot of cash on hand will create. That's the first thing. Second, the fact that the IRS under Section 280E does not allow deductions or credits offered to other federally legal businesses in the U.S. That does squeeze the budget pretty tight for most operators. I wondered what we could do as a state to alleviate that. Again, I'm a veteran. I 100% agree with the revenues as they're being spent, the 4%. But I wonder, as a state, what we could do. Again, this would be Department of Health working with the Missouri Department of Revenue to say, if there could be an incentive created on the state return for operators, especially considering that they're being squeezed by the feds. Some sentiment from the crowd tonight pointed to like a kind of a middle ground of cultivators, you know, like smaller than the 30,000 square feet and, you know, the outdoor maximums. And I do think that the Caregiver Collective that was spoken about earlier is a good opportunity for that, especially in rural parts of the state. You know, if you're in down the Ozarks or up north, and there's not much of a market for it, it just seems to be a good alternative. I definitely think that the scoring of the applications should be done independently, and you know, we're all waiting for the draft rules to come out. I'm sure there'll be further guidance as to how the scoring will be evaluated. One thing I wondered, and following the good veteran, Reverend here, one thing I wondered is, you know, if an operator found a space that was within 1,000 feet of the regulation of a church or school, is it possible to get a letter of consent from that church or school to set up shop? Like, if there could be some kind of conditional permittance, obviously subject to whatever specific church or school. Also, I believe that the school requirement is intended to shield or protect children. If we could get a conditional, like, you know, primary school or high school even, whereas like a driver school wouldn't be subject to that same regulation, when, you know, obviously driver school is for adults, or, you know, a university which is for adults. We could get the condition for the school. I definitely think reciprocity for patients is important. I definitely think that the Department of Health could have a scoring system of their own for other states, to say this state, their regulations are up to par with ours, so we will, respect their patients, their ID card holding patients. And then one last thing, and sentiment from, you know, the crowd of, I guess this is my last point, if I could just ask it as a question. The application fee that we do pay, if we don't get selected to be awarded a license on the first round, is there any way to earmark that for a second application? You know, if we don't meet the first wave, you know, we don't have to pay another application fee if we are intending to submit another application. I don't know if that's
I don't know the answer to that. It's a good question, but I do not know that.
I understand it's not fundable, but like, you know, if it could be like, you know, again, earmarked for the same entity or whatever.
Sure, I understand what you're saying. You're going to submit your issues to us in.
Can I just send you an email? I don't have like a very good paper for it.
Absolutely. Email would be great. That'd be fine.
Okay.
Yeah.
Thank you.
You're bet. Thank you very much. I think I will address another issue, Rob, because the 1,000-foot rule is something that's come up several times, and it's my understanding the way the intent of the amendment is that if a locality wants to loosen that restriction, make it less, then they can do that. So I think the way the wording is, yes, sir.
That is true.
Yes.
But as an owner-operator, paying $10,000 and investing roughly $750,000 before a plant even pops out of the ground in 12 weeks, let's say you lower the limit to 500, but the federal is still 1,000, and in Missouri, it's only one or three states that has a 2,000 drug-free zone. So that local municipality can lower it, but if I'm coming in there with him and we're spending our money and putting all this together, and now the feds come in and the city council said, we said 200. And the feds said, well, ours says 1,000 and the Missouri statute says 2. So I'm coming to your door hot. So that's nice, but it doesn't fix the implications that we have. I mean, we're in there. What if the feds can still come down on us? So you're right. But be careful, I'm
Yeah.
sorry,
No, it's fine.
if you carry weight.
Sure.
I'd add to that, I've met with about 9 cities now, and probably out of the 9, 7 have, first of all 9 were in favor. In other words, they're all very open. I encourage everyone, if you've got any ideas at all, you get with the cities right now, because it's a pretty long process, and you're bumping up against that to get the ordinances in place. And out of that 9, about 6 of them have been very open and have lowered that 1,000-foot requirement. So I just leave that to people, that the city reception we're getting is, and some of them are really large cities.
Thank you. Cameron Shafula? Cameron, all right, Cameron.
That works.
Got that part right.
First, I'd like to preface this by saying thank you for having these, holding these, allowing the public to come in and share their opinions. Limit on vegetative plants is the equivalent of the number of sunflowers I can grow on my patio, with the added bonus that I'm being deprived of the opportunity of possible treatment options. Would you not want to pick out the biggest sunflower you have, to snip it and give it to your mom on Sunday after church? Would you not want to choose the seeds from the one that grew the biggest, had the most beautiful colors, all that good stuff? Would you not want the strongest one that held up to the weather that we experience in this lovely state? Cannabis is a plant like any other, and they vary from seed to seed. Maintaining consistency is the biggest argument against a limit on plants in the vegetative state. Perhaps your doctor recommends a different type of strain. You currently have 6 plants because you're ensuring you have enough medicine to mitigate your condition or symptoms. Sorry. But what if there's an accident and you knock one over because you have a disability? To put it nicely, stuff happens. Do you put yourself at risk and try to follow the doctor's orders, go without for a time, or miss out on an opportunity that might have been life-changing? Miss out on an opportunity that might have been life-changing given your situation, all because of an arbitrary limit on what is in essence a houseplant. The department's job is to codify our will. I would hate to see burdensome regulations thrown at it. I challenge the department to learn more about cannabis, its effects, and its possibilities without falling in with the lusty trappings of its exponentially worrisome corporate interests, flip-flopping supporters, and reefer madness level hysterics.
Thank you, Aaron. Renee Pearson.
Thank you for this opportunity. Just a couple of things. Most of the things that I had on my list, everybody's touched on, so I won't touch on them again other than to go right on. One thing, though, I really did want to touch on is one gentleman talked about the testing. And I've been in the cannabis industry for 4 years. And when we would go to legal states, some of the states in their testing for microbes, we found out that the governmental department that was actually doing the testing had no scientists in the department and no agricultural people. So it was kind of an arbitrary thing. And they were throwing out whole grows of cannabis buds because they were taking the microbes on a full count, and they weren't differentiating between good and bad. So there's good microbes and there's bad microbes. That's life. They keep each other in check. So you have to differentiate between the good and the bad in your testing. I'm standing up here as a person who has no colon because the doctors killed every bacteria in my body. And from that point on, it just went haywire. So, doctor that was back there, I salute him for getting up here and talking about that. About the difficulty for cultivators in the state to be able to start growing and have product for the patients as soon as they need it. I don't know if, I just had a thought, if there could be another license that's put in, maybe pre-patient license, before the patients get their licenses, for cultivators that have already filed to allow them to grow only mother plants, no flowering plants, just so that if and when they do get their license, they can hit the ground running. That way it keeps it in our state, it keeps us all legal. So that's, and then the whole gun permit thing, it seems like it's in direct opposition to what we have to do as cultivators or as dispensaries, because we have to have security, which might mean armed guards. Well, an armed guard is working for a cannabis industry, but he's not allowed to have a gun. I mean, it just doesn't make sense. So something needs to be done about that, I think. And that's all I've got. Thank you.
Thank you very much. Zachary Rubin. Zachary, you're the last speaker.
Okay. Thank you for letting me speak today. I have a few comments and suggestions. One of the things that I wanted to make sure is that the pre-filed applications don't get preference over people who have not deposited money yet. This was a vague process. It's a very expensive, non-refundable deposit. I am in favor of granting licenses, or smaller cultivation licenses, but I want to make sure that there is a limit on the number of licenses that the state does put out for cultivation. Basically, in Oregon, what happened was the state set no limits on cannabis cultivation like they did on liquor stores. So what happened was the market became flooded and the price collapsed. So what I'd like to see is that there is some kind of limitations so that there's protections for small farmers, small business, and local Missourians. Because if the price collapses, that's who it's going to hit hardest. And on top of that, you'll see the black market get flooded, and you'll see only large businesses that can afford to do high volume survive at the low margins that they'll be able to receive. And I would like to see the strict monthly limits on the amount that patients can possess. I'd like you guys to reconsider that. I think it's very hard for caregivers to try and grow to these strict limitations of what they can possess and what their patients can possess. So, thank you for your time.
Thank you. I'd like to remind everyone to send that information in on our email, or welcome to mail it in if you have it written down or hand it to us tonight. Great, thank you. Oh, sure, yeah, go ahead.
Scotty Warner, Clay County, Kansas City, Missouri. Just wanted to mention that as you see on your screen, you've got the number of apps put in for cultivation, dispensary, infused. Is there a possibility to go ahead and stretching that out? How many of each per district? For an example, I think I looked a few days ago, this District 5, I believe it's in 54. Is that all cultivation? What type of app was per district? Because I'm thinking maybe the district north of us would, I guess what I'm getting at, if there's so many apps for, say, cultivation in Kansas City, there's a better chance I wouldn't get a license or whomever. So maybe I would, when I apply, if that's going to be a mandate to where is this going to be, I'd choose a different district to do my cultivation. Does that make sense?
Yeah, we have listed, that's the dispensaries, right, Cheryl? We do have the dispensaries broke out by district. I don't know if you knew that or had seen that, sir, but that's the dispensaries.
Oh, that's just dispensaries?
Yeah, just dispensaries. We don't have the other two categories. We'll take that back and talk to the team and the director about that. I'm not sure if we can or can't, but if we can, we will.
Yeah, if you could break out the other
Yeah,
two.
cultivation and manufacturing.
Thank you.
Thank you.
Appreciate it.
You bet.
Break out the, if you didn't, or the, you break out all into like 5 entities, you know, you've got the transportation, and you got, so if you could break out all of those, that would be, because I hear that there's not the rumor is that there's not a lot of people applying for the transportation, you know, to move the product, so.
Yeah, actually, the only pre-application fees that we're receiving are cultivation, manufacturing, and dispensaries. The transportation doesn't require a license for the amendment. It will require a certification of some sort by us, but it's not one of the fee
And you'll be sharing
licenses.
those before the rules on that.
Absolutely, that'll be part of the rules,
Good to know.
yeah,
Thank
be part of the rules. I would like to thank the University of Missouri here at Kansas City. We've had tremendous support by the universities, the colleges in the state. The other seminars or forums that we've had have been at the community colleges in San Luis, Poplar Bluff, and Springfield, and they've all been extremely welcoming and helpful and great facility. This is a great facility, and we just like to give a big round of applause to the university for helping us. It's a big deal to facility large enough to accommodate a group like this, and it's been really good. I'd like to thank Joe and Crystal and Valerie from the department back there. They came in to help us at the tables, and appreciate that. And Cheryl, she's, like I said, she's the eyes and ears of our department sometimes. She takes a lot of the questions and the concerns from people, so we appreciate her. But thanks again, tremendous input, great comments, and we will take them back and consider and implement what we can and work the real process harder than we are now. So we're trying to get things rolling for our state. But thanks again, we sure appreciate it. Thank you.